Thank you, David, for that. I think that's what corporate responsibility looks like. And when you have time, I probably will come by and try to learn how you can speak so fast and never stumble once.
Yeah.
Next up, we get a glimpse into something that every healthcare company, startup, hospital, and regulator is trying to figure out, and that is value-based contracting. As the healthcare industry lumbers unsteadily toward paying for outcomes instead of paying for services rendered, what are the priorities of private payers? For that, we'll have to turn to Scott Hewitt, who is VP of Value-Based Contracting Strategy at UnitedHealthcare.
Thank you very much. Sitting in the back today, I've sort of, who's familiar with the 7 degrees of separation from Kevin Bacon, right? Like almost everybody's gonna raise their hand. So as we've been sitting, listening to all these presentations, Shayla's first presentation, I went to the University of Minnesota, got my grad degree in public health. I didn't have the option of going to Uganda like he did, or the students do now, so I feel like I missed something there. My first job after grad school is I went to work at Health Partners, so where Britt came from, and my first manager was actually one of the individuals that started the Uganda project that she talked about. And then now with David speaking, actually Lisa Woods and I have been on a number of panels across the country, a number of work groups focused on value-based contracting. So unbeknownst to the organization that pulled us all together, it's sort of like one connection after another, which I think is really exciting. If you guys will give me a moment, I'm going to see if I can be as successful as David and find my presentation. At this point, I can't even find the mouse, so I might need some help up here, guys. I'm going to call help. I'm calling an audible. I need some help. So while I'm getting some help, I wanted to start with a brief story for all of you. Imagine that you are a 33-year-old woman. So for you men out there, imagine this is your sister, your wife, thank you very much, your daughter, friend. We all know 33-year-old women. You find a lump. You're not really sure what it is, and you go to your primary care physician. Your primary care physician tells you, don't worry about it. It's nothing. It's too small. Don't be concerned with it. So you forget about it. And a couple months later, you go to your OBGYN and you say, oh, by the way, I've got this lump in my left breast. My primary care physician said not to worry about it, but it hasn't gone away. I'm a little bit concerned. What do you think? So the OBGYN does an exam, says, you know what, I really don't think this is a big deal. Why don't you come back in another 3 months? So now 6 months has gone by. You've got this lump. You're concerned about it, but nobody's really taking it all that seriously. So you finally get to go to a radiologist, and you have a mammography done. And the mammography finds something. They do a biopsy, and sure enough, it's cancerous. So your primary care physician says, you need to find a surgeon to remove this. You're all alone. You don't know what to do. You know, who do I decide to pick for a surgeon? I don't know anything about surgeons. Well, here's a list of who we would recommend. Pick the one that sounds good to you. So you pick one, and you talk to that surgeon, and the surgeon says, you're also going to need to find your own plastic surgeon, because I don't do the plastic surgery. I just do the mastectomy. So, well, how do I find a plastic surgeon? Once again, here's a list. These are the ones that we use. This guy here at the top, he's the best one in the area. Use this guy. You go talk to that guy, and the bedside manners are awful. But you feel, if this is really the top guy, bedside manners aren't that all important. I'm going to go with who the doctors tell me is the best in the area. Complications happen with the reconstructive surgery, to the point where the plastic surgeon actually locks the door with you in the room and says, why did you come to me to begin with? If you didn't think my work was going to turn out, why did you select me? Well, my surgeon told me to select you. That's why. I don't even know who your surgeon is. I've never dealt with that person before in my life. This was my wife's story. So this didn't happen in one of our countries that we work with. This happened 6 miles down the road. I'm from from Minnesota. 6 miles down the road this happened. We had to coordinate everything associated with her breast cancer. We had to bring the lab results. We had to bring the physician notes. We had to bring them from one doctor to the next, and on and on and on. Now, this was 9 years ago. She's doing great. Everything's wonderful. But it was really at that point in my career that I said, things can happen differently. We can engage the provider network differently. If we can have an experience where the members feel that the physicians really are putting them at the center of their care, they're going to be happier. They're going to get better results. The whole system is going to work better. So that's what I've been working on for the last 9 years, is how can we bring a better member experience to the healthcare landscape. Now, at UnitedHealthcare, our mission is helping people live healthier lives and helping make the health system work better for everyone. That's not limited to UnitedHealthcare members. We really are focused on how can we improve the overall landscape in which care is delivered and care is received. Now, most recently, I joined our UnitedHealthcare global team. So on the slide here, I'm not going to go through the stats, but most people don't understand the size and scope of UnitedHealthcare, UnitedHealth Group as an organization. We've got over 285,000 employees worldwide now. And really, if you look here at the map, you can see where our growth has been in the Latin American companies, over into Europe. And it's not a spoke and wheel system in terms of with the spoke being the United States, and we want to deliver the best care and best practices from the United States and push them out to the other parts of the world. We really think that it's more of a spider web. What can we learn from Brazil in terms of their best practices and bring that to Portugal, or in turn bring that back to the United States? Because there's a lot of learnings that are happening out there. I think one of the things that Britt mentioned earlier was that at Health Partners, they're bringing together all of those co-ops on an annual basis, or a quarterly basis, I think she said, to share best practices. Here in the United States, we do something very similar with our larger health systems, those health systems that are focused on population health. We happen to call them ACOs, Accountable Care Organizations. In the United States, we bring all of those organizations together on an annual basis, in person, and actually they present to each other. So it's not UnitedHealthcare getting up at the front of the room and talking about best practices. It's these ACOs that are getting up in front of each other saying, this is how I've been successful at solving X, or this is how I've been successful at dealing with Y. As an example, if I ask all of you in the room by show of hands, if I say, think of a Corona commercial, Corona beer commercial. If I said, does a beach come to mind? Show of hands. How many people are going to show me yes, Corona Beach, like a Corona beer beach commercial, that's what happens. One of our ACO groups in Ohio actually put a billboard up in their town that said, where do you want to spend $5,000? Don't go to the ER, go see your primary care physician. And it's just 2 feet on an ocean, but it hit everybody in that room, right? I mean, this is a best practice from a group in Ohio. And that was shared across all of the ACOs, and people were asking for who's your marketing director and who's the ad agency that you use on these things. The point of that story is the similar thing needs to happen in a global space. So what are those best practices that we can take from around the world and bring them back to the United States, or bring them from the United States out to other parts of the country? Now, one area that's been really successful is in Brazil. In Brazil, the literal translation is health club. And when I first heard about this, I actually had to ask. I said, so do we have like treadmills and elliptical machines in these health clubs? And they said, no, there's no exercise happening in these health clubs. What's actually the health club is almost like a primary care home or a patient-centered medical home, that we would use that terminology here in the United States. And what they did down in Brazil is they looked at the data and focused on the top 3,000 most expensive members. And they just made reach out calls to all of them and said, we've got this health club, which includes physicians, it includes nurses, it includes non-clinical individuals, to really help focus the care around those individuals. And to the point where we'll actually go out to a member's house. The primary care physician, if the member's having problems, they can call the health club and the physician will come to their house instead of that member going to the ER. In Brazil, the primary care is a specialty. So we heard earlier from Andy that we need more primary care specialists. In Brazil, actually, primary care is a specialty. Most people access the healthcare system through the ER. That is their first choice, is just to enter the ER. Actually, physicians schedule surgeries by saying, I will meet you in the ER on Tuesday at 10 o'clock. Go to the ER, get yourself admitted through the ER, and then we'll do surgery on you. So it works very differently than it does here in the United States. So as a result, we created these health clubs and had used it as an opportunity to see if we could engage members differently. And really, it gets to this, this statement that I think you've heard through the first three presentations, and now you're hearing with mine, in terms of we need to be thinking globally, but acting locally. So what are those best practices that we can take from around the world, but have them apply where it makes more sense, or with that population that makes more sense? So when UnitedHealthcare first moved to Brazil, or when we first moved into that space, we tried to deploy some of the same tools and technology we've used here in the United States in terms of care management. I'm sure every one of you, if you've got insurance through your employer, has interacted with your insurance company in one form or another. Whether it's you had to get prior auth for something, they called you and said, hey, we noticed you had X. We think that you should do Y as a result. That model was very successful here in the United States. UnitedHealthcare, all the major payers, all the small payers, everybody uses that model here in the United States. In Brazil, the model was completely a major failure. It didn't work. But then when we created those health clubs, where now these health clubs were staffed with physicians, and those physicians were making the outreach, those physicians were the ones calling the members, the engagement improved exponentially, to the point where savings from these programs or the cost of these members dropped over 26% in 1 year. And it just had to do with how we were engaging the members differently. So when we think about it here at UnitedHealthcare or more globally, I think these stats that I'm throwing up here on the slide or on the screen are nothing new to any of you. They're really, how are we going to interact differently? The dynamics have changed. The landscape has changed. We need to work with each other differently. So here in the United States, where we've really been expanding in the value-based care setting, like as I mentioned, Lisa and I have sat on a number of panels. We sat on some work groups with CMS to try to help them define what is value-based contracting. If you're familiar with the LAN, the Learning and Action Network, and CMS and their 4 categories of how care is contracted, Lisa and I have, I guess, the battle scars on our back from the very first work groups associated with those in terms of categories 1 through 4. But we need to take those learnings that we've had here in the United States and bring them out more broadly. And so some of the things that we're seeing is, as I mentioned, with those health clubs, that we've seen that those 300,000 members that I talked about that we first focused on in terms of those were our high utilizing members. They represented 33% of our overall costs as an enterprise. So by reaching out to them, and I mentioned the 26% reduction that we saw in their cost, that's a huge savings for that population, for those employers down in Brazil. We took those same learnings and are bringing them back to the United States. So we recently piloted with 6 different health systems here in the United States. So using that same thinking mentality of the health club or the patient-centered medical home in Brazil, where we focused on these high-cost members, we came back to the United States and shared with 6 different organizations who their high-utilizing ER members were. We had one sticks out in my mind in particular. There was one organization that had a member that went to the ER 170 times in a 12-month span, and another member that went to the ER 210 times in a 12-month span. Literally going to multiple ERs in the same day because they didn't like the answer at one. Another organization, this happened to be a pediatric group, clearly not to the same numbers in terms of 170 or 210 visits on an annual basis, but it was 9 visits to the ER for a child less than 2. Now, 9 doesn't sound all that great, but for a child, that's a lot of the time to go to the ER. Now, the learnings from Brazil in terms of let's get the physicians more engaged, let's get the data in the hands of the physicians, what we learned is it really wasn't anything wrong with that child. It was actually the mother and the mother's history, the mother's behavioral mental health status that was causing these 9 visits. So what can we do in that regard? The individual who went to the ER 210 times, I just realized as I was standing here on stage, so this is nothing against Lisa or David. He was actually, would go to Walmart and OD on drugs in Walmart and tell a Walmart associate that I just OD'd on drugs in your store, and to their credit, they would get him to the ER immediately, to the point where he has never had any liver damage in all of these drugs overdoses in the Walmart store. So kudos to Walmart in getting the ambulances there. What the connection to Walmart is, what we have since learned is that he had troubles as a home, and I can go through the number of physical, sexual, whatever abuse by his father, who all he remembers is being with his father in Walmart as a kid. And so he was playing out something from his history in Walmart on 210 times a year. So not to bring people down on that note by any stretch of the imagination. The point being, there's so much we can learn from each other here in the United States and more broadly. And I think going back to my previous slide about think globally, act locally, it resonated with every one of the presentations we've had so far today. I'm guessing with the next couple of presentations, that same mentality or that same mantra is going to come forth. Think globally, act locally. And if we can do that, I think we're going to see some really significant changes in the way healthcare is delivered, the way healthcare is received. Happy to answer any questions or stick around after the next couple of presentations. Thank you, guys.
So we'll take a short break right now and reconvene at 3:15. There are beverages and snacks out there, so please feel free to grab those.
Oh, thank you.
Tim Anderson.
Nice to meet you, Tim.
Company that I think we might be able to work together. I do